Thank you, Chairman. I'm Dr. Henry Fu. I'm coming from Hong Kong, from the Department of Orthopedics and Traumatology, Queen Mary Hospital. I'm coming here on behalf of Dr. C.H. Yan to present his study on the use of body exhaust system in primary total knee arthroplasty randomized trials. So prevention of infection after total knee arthroplasty is of utmost importance because we are doing increasing number of total knee arthroplasties globally. Periprosthetic joint infection remains the #1 cause of failure nowadays. And back in the days of Sir John Charney in the 1960s, he first developed the greenhouse to prevent infection, which later on developed into the body exhaust system. But at that time, in the 1970s, the body exhaust system was different from the ones we use nowadays. It provides a negative pressure and sucks the air out of the body exhaust system. But nowadays, the body exhaust system, we have a fan in the helmet and provides positive pressure. But there is contradicting evidence concerning the use of body exhaust systems, especially if you look at the New Zealand Joint Registry. They think that there is increased risk of periprosthetic joint infection with body exhaust system. But why is that? So that's why we performed this study. We conducted 2 randomized control trials. First part involved an operation comparing the intraoperative wound contamination in primary total knee arthroplasties and postoperative infection rate between using spacesuit and just conventional gowning. The second part of the trial involved finding the potential source of contamination in the spacesuit. We performed a simulation study to look specifically at the glove-gown interface. The first part of the study involved operation. We performed 1-stage bilateral total knee arthroplasty in 32 patients, one side wearing the body exhaust system, the other side with conventional gowning by the same surgical team. So between the 2 sides, we degowned and changed the gown. And we randomized in terms of sequence, whether we did a body exhaust system first or conventional gowning first, and the side of the surgery, left or right. And we took 5 wound swabs in different stages of the surgery. First part is during the subcutaneous layer following skin incision. The second part was after the bone cuts. We took a wound swab over the proximal tibia before we implant. Third part is taking it from the distal femur after the bone cut before implantation. Fourth one was taken over the anterior femoral condyle of the implant before closure of the arthrotomy. And the last one was taken again after closure of arthrotomy in the subcutaneous layer. And the wound swabs were immediately processed in the microbiology lab, and quantitative and qualitative bacterial cultures were kept for 48 hours. All patients were followed up to 1 year, and detecting of early infection and wound complications was noted. So these are our results. We did 22 female patients, 10 male patients. Mean age was 68 years old. There were no significant differences in terms of the body mass index, degree of deformity, and the operative time. Interestingly, we showed that the surgeons actually touched the helmet on average of 1.6 times. So during the surgery when they used the body exhaust system, and the number of times the surgeon changed the gloves was also slightly different. With conventional gowning, changing the gloves were more frequent. We showed no positive growth from all the intraoperative swabs over both groups, and there were no early postoperative infection or wound complications in up to 1 year's follow-up. Second part of the study was a simulation. We used 5 micrometer fluorescent powder, which is a surrogate for bacterial-laden skin particles, applied them to the hands of one single surgeon, and we also applied the body exhaust system, where the patient put on the body exhaust system and double gloves. One side of the hands, we taped the glove gown interface, and the other side, there was no taping of the sleeves. You can see the difference down here. This side is taped, and this side was not taped. And we did a simulated total knee arthroplasty sawbone surgery, which lasted around 60 minutes. We took pictures with fluorescence plots at 15-minute intervals. So the top part shows the parts that are not taped. The bottom is taped. You can see that under fluorescent lighting, by 60 minutes time, there is quite a lot of fluorescence spot that escaped the glove gown interface going onto the outside of the gown in the patients that in the side that is not taped. Whereas for the ones that is taped, there was not much fluorescence spot escaped. So discussion. We found that wound contamination at the time of procedure might be a cause of early postoperative infection, particularly with the modern body exhaust system where there is positive pressure. The glove gown interface may be a potential source of leakage, and whether or not there is increased wound contamination remains to be studied. Concerning the operative side of the study, we found no growth from all the wound swabs, no early infection also. And for the body exhaust system, there was no significant difference in terms of the incidence of periprosthetic joint infection. For the simulation part of the study, we found that the glove gown interface might be a source of contamination, and that adhesive taping over the glove gown interface can potentially reduce the leakage. Body exhaust system also should not be considered sterile. We find that the surgeons sometimes would touch the surgical helmet, and we do advise the glove change after contact with the surgical helmet. It should not become a false sense of security and let us neglect other preventive measures and potentially increase the infection risk. But still, we would advise to use body exhaust systems for other concerns because we can protect the surgeons. You can see that this is a picture of Dr. Yan with his body exhaust system. You can see that there are a lot of fluid particles on the shield of the body exhaust system, which can be prevented with this. And if we do apply adhesive tape at the glove gown interface, apply double gloves, it may also reduce the risk of contamination. So once again, I thank you all for inviting me. I come from Hong Kong, Queen Mary Hospital, Duchess of Kent Children's Hospital, and this is my surgical team. And I'd like to thank my boss, Dr. C.H. Yan, Professor Peter Chiu, for allowing me with this opportunity, as well as Dr. Wong from the Hong Kong Orthopedic Association. Thank you very much.